How does anticholinergic toxidromes present? When should physostigmine be used over benzodiazepines? What's the current status of physostigmine's availability? Hello there, farmers and friends. Mark with FarmWise. I'm a board-certified emergency medicine pharmacist that makes clinical pharmacotherapy content on the social medias. Welcome to the Code Blue Debrief, a clinical pharmacotherapy YouTube and podcast series. If this is the first time you're on my channel today, make sure to hit the follow and notification bell for more farm facts deposits in your drug bank. I post daily infographics, reels, and patient cases on the social medias. For today's episode, we'll be discussing anticholinergic toxicities and the use of physostigmine. When I was a second-year resident, the FDA released a warning in September of 2020 regarding the dangers of taking more than the recommended amount of over-the-counter Benadryl, which is the brand name for the allergy medication diphenhydramine. Young kids at the time were on TikTok participating in the Benadryl challenge, posting videos of themselves taking large amounts of diphenhydramine. This fad was brought into the spotlight by the media, but unfortunately, diphenhydramine has been a common intentional and unintentional ingestion even prior to this trend. Anticholinergics are easily accessible as over-the-counter sleep aids and allergy medications. Don't forget about prescribed anticholinergics such as hydroxyzine, and those with minor properties including cyclobenzaprine. Let's review the anticholinergic toxidrome, in addition to primary and secondary pharmacologic contributors.
Anticholinergic toxidrome.
For a little flashback to Pharmacology 101, we associate the sympathetic nervous system with the fight or flight response, while the parasympathetic nervous system is more deemed as the rest and digest period. Acetylcholine is the primary neurotransmitter in the parasympathetic nervous system that binds to nicotinic and muscarinic receptors. Organophosphates can cause cholinergic excess, leading to toxicities with salivation, lacrimation, urination, defecation, GI distress, and emesis, or sludge. This gives you some context, since the anticholinergic toxidrome is the complete opposite. Poisonings can be centrally and peripherally acting. In the periphery, symptoms include hypertension, tachycardia, decreased bowel motility, urinary retention, and dry mucosal membranes. Progressive symptoms associated with central toxicities include confusion, agitation, delirium, hallucinations, seizures, and then coma. You commonly hear blind as a bat, mad as a hatter, dry as a bone, red as a beet, hot as a hair, and full as a flask to remember the anticholinergic toxidrome. When we think of anticholinergics, diphenhydramine often comes to mind first since it's available over the counter. Other antimuscarinics that don't require a prescription include cetirizine, loratadine, meclizine, and doxylamine, amongst many others. The older antihistamines, such as doxylamine and diphenhydramine, are more used as sleep aids given their centrally acting sedative effects. Polypharmacy has been an ongoing concern in medicine. Medications have several considerations with interactions, metabolism, and elimination as we age. Anticholinergic toxicities are often precipitated unknowingly from secondary medications. Drugs with anticholinergic properties are antidopaminergics, including quetiapine and olanzapine, as well as tricyclic antidepressants and cyclobenzaprine. With any concerns for poisonings, contact your poison control center and consult your pharmacist.
Antidote, physostigmine.
Our antidote for antimuscarinic poisonings is going to be physostigmine, specifically for anticholinergic-induced delirium. By inhibiting acetylcholinesterase, increased acetylcholine becomes available at the synapses. As a tertiary amine, it readily crosses the blood-brain barrier to reverse the effects of antimuscarinic poisonings. Physostigmine is dosed at 0.5 to 2 milligrams and may be repeated every 10 to 30 minutes as needed. Make sure to administer no faster than 1 milligram per minute to minimize the risk of bradycardia, respiratory distress, and seizures. It's important to note that physostigmine has a short half-life with a duration of an hour. Severe ingestions are going to require repeat doses and a continuous infusion. Start your infusion at 1 milligram per hour, titrated every 30 minutes to clinical effect. The onset is within 5 minutes IV, and within 20 when given intramuscularly. I'm all for anyone who wants to hop on the Ativan ride for acute agitation. However, physostigmine is going to be our agent of choice for antimuscarinic induced delirium. Benzodiazepines don't address the underlying toxic mechanism while increasing the risk of oversedation and respiratory distress with copious use. Benzodiazepines are often considered first line for undifferentiated agitation, but preference should shift towards physostigmine with delirium and as patient workup and diagnostics point towards anticholinergic toxicities. The fear of physostigmine comes from early case reports that resulted in 2 deaths after overdosing on tricyclic antidepressants and receiving physostigmine. This led to the black box warning of being contraindicated with concerns for a TCA overdose. Physostigmine should be avoided in patients with a widened QRS, AV block, or bradycardia. Under these circumstances, physostigmine may worsen conduction disturbances and cause bradyarrhythmias or asystole. Precipitation of seizures is another concern for physostigmine. This can be avoided by diluting each physostigmine dose of 0.5 to 1 mg in 10 milliliters of D5W or NS. Make sure to administer as a slow IV push over 2 to 5 minutes. Benzodiazepines will be our treatment option specifically for seizures, while physostigmine addresses delirium. Wang and colleagues performed a randomized blinded trial in 2021 with patients presenting with anticholinergic toxicities. They included 52 patients aged 10 to 17 years old, had at least 1 central and 2 peripheral antimuscarinic symptoms, delirium, and moderate agitation. Patients would receive either lorazepam 0.05 mg per kilogram as a bolus, followed by a 4-hour infusion of normal saline, or they would receive physostigmine 0.02 mg per kilogram as an IV bolus, followed by a continuous infusion at 0.02 mg per kilogram per hour. From their analysis, physostigmine was superior to lorazepam in controlling antimuscarinic-induced delirium and agitation. Additionally, they didn't detect any serious adverse events. In 2015, Watkins and colleagues conducted a retrospective analysis of the Toxicology Investigators Consortium Registry, which includes data that medical toxicologists contribute to. They identified patients with an anticholinergic toxidrome, agents received including benzodiazepines and antipsychotics, and classified them into treatment groups. Patients who received only physostigmine had lower rates of intubation compared to the other regimens. Those presenting with mixed symptoms had much lower use than those presenting with primarily anticholinergic effects. However, even patients with anticholinergic toxicity were more likely to receive benzodiazepines than physostigmine.
Physostigmine availability.
Physostigmine is an awesome drug for antimuscarinic-induced delirium. Although we've been undergoing supply and demand issues recently, the manufacturer went bankrupt and shut down their facility, leaving no manufacturer in the US to make physostigmine available. We were left with limited options to treat anticholinergic toxicities and resorted to uncommon alternatives. An example would be rivastigmine orally or transdermally, which has shown to be effective in treating anticholinergic poisonings with ongoing supply issues. Just recently, on October 31st of 2023, the FDA released a statement that there would be temporary importation available for physostigmine from Pfarm in Germany.
Know what you have available.
You can recall the anticholinergic toxidrome with blind as a bat, mad as a hatter, dry as a bone, red as a beet, hot as a hair, and full as a flask. Physostigmine is the preferred agent for antimuscarinic-induced delirium. It's important to note that it has a short half-life with a duration of an hour, and severe ingestions will likely require a continuous infusion. To reduce the incidence of adverse drug reactions, such as bradycardia and inducing seizures, it would be preferable to give it as a slow IV push. As with any other medication in your drug bank, know what you currently have available and what important therapies are on shortage. This may require you to think outside of the box and become familiar with alternatives based on limited evidence. It seems that our physostigmine issues are temporarily fixed, but let me know in the comments below. What are your thoughts on the use of rivastigmine as an alternative to physostigmine? Thanks for staying to the end of this episode. If you enjoyed the content today, make sure to give the video a thumbs up and check out my other pharmacotherapy posts on the social medias, and I hope you learned something new.